Indication: CABOMETYX, cabozantinib, is indicated for the treatment of patients with hepatocellular carcinoma, HCC, who have been previously treated with sorafenib. Select important safety information. The full prescribing information for CABOMETYX includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar plantar erythrodysesthesia, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hi, I'm Dr. Julio Gutierrez, an associate professor of medicine, hepatologist, and liver cancer specialist at Scripps Previs Cancer Center in San Diego. I lead an active transplant hepatology practice focusing especially on underserved populations in Southern California.
And I'm Dr. Joshua Strauss, a community hematologist-oncologist. Since completing my fellowship at Columbia University in New York, I've been working in practice in New Jersey.
Today on CABOMETYX in Conversation, we're going to be talking about Adam, a hypothetical patient with hepatocellular carcinoma, or HCC, and how Dr. Strauss decides on his second-line treatment.
Adam is 66 years old. He has cirrhosis related to chronic alcohol consumption. He reported to the ER with abdominal discomfort. An abdominal CT scan revealed at least 5 nodules in the liver, with the largest being greater than 5 centimeters, macrovascular invasion, and some metastases in the local lymph nodes. A biopsy confirmed he had unresectable advanced HCC. Adam was treated with systemic therapy in the first line for 6 months before a restaging CT scan revealed both bone and lung metastases.
So, Dr. Strauss, after his progression on first-line systemic therapy, how would you ultimately choose to treat Adam?
I would prescribe CABOMETYX.
Why CABOMETYX?
A lot of it comes down to the evidence. The treatment landscape has evolved over the last few years, and I look to the data from the clinical studies to help inform my treatment decision-making. In Adam's case, and for others like him, I find the Celestial trial helpful. It was a double-blind trial of 707 Child-Pugh A HCC patients randomized in a 2-to-1 fashion to receive either CABOMETYX or placebo following sorafenib. It didn't exclude patients who had bile duct invasion or greater than 50% liver involvement. It included patients who had received prior immunotherapies. And most relevant to Adam, 79% of the patients who received CABOMETYX had extrahepatic spread, and 27% had macrovascular invasion.
Something I also like about the Celestial trial when we're thinking about Adam and patients like him is that the trial also had a large second-line population. All patients had received prior sorafenib, and 71% of the patients in the CABOMETYX arm were second-line.
Exactly.
So, what is the efficacy evidence from Celestial that would lead you to choose CABOMETYX?
Well, if you look at the intent to treat population, patients receiving CABOMETYX had a longer median overall survival, 10.2 versus 8 months, and a longer median progression-free survival, 5.2 versus 1.9 months, than those receiving placebo. Then, when looking at results from a pre-specified subgroup analysis for the 71% of patients who received CABOMETYX in the second line, the median OS was 11.4 months versus 7.7 months in the placebo arm. And the median PFS was 5.5 months in the CABOMETYX arm versus 1.9 months in the placebo arm. Because this is exploratory, no statistical procedure was employed, and results should be considered hypothesis generating.
I think the disease control rates are also important to talk about. The objective response rate in the CABOMETYX arm was 4%, and then 60% of patients experienced stable disease, for an overall disease control rate of 64%. CABOMETYX stalled tumor growth for a lot of patients.
That's another reason I like it for Adam.
Also, based on my clinical experience, the adverse reactions observed in the Celestial trial were in line with what I'd expect to see with CABOMETYX. The most common ARs in the ITT population, with an incidence of greater than or equal to 20%, were diarrhea, fatigue, PPE, hypertension, vomiting, nausea, and decreased appetite.
There's guideline support for this as well.
Yes, it has a Category 1 recommendation from the National Comprehensive Cancer Network as a subsequent line treatment option for HCC.
The other factor that's important to me is the once daily oral dosing. In Adam's case, he wanted to maintain his daily routine and avoid frequent trips to the infusion center.
That's also something I consider when I have a sick patient who's coming close to the end of life.
It definitely plays a role in my decision making.
So, in summary, you selected CABOMETYX as a treatment option for Adam because the Celestial trial had second-line efficacy and safety data, had data from a representative patient population with extrahepatic spread and macrovascular invasion, and because it had once daily oral dosing. Is that right?
That's right, yes.
Thank you so much for taking the time to walk through that case and your thinking.
It was my pleasure. And I'm looking forward to discussing our next patient case. Stay tuned for our upcoming CABOMETYX in Conversation session.
Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.